Hi, my name is Dr. Reynolds, and today I'm going to be performing an osteopathic respiratory exam. So to start with this exam, what I'm going to do is just observe you breathing here for a second, okay? And so while I'm observing you, I'm just going to be noticing to see if there are any signs of distress while you're breathing. So I'm looking at the color of your face, which is a sign of perfusion, and looking around your lips to see if there's any bluing of your lips. It looks like you're breathing comfortably through your nose. I'm seeing pretty symmetrical chest rise here. I'm going to take a look at your trachea and make sure that your trachea is midline. It's not deviated to one side or another. I'm also looking at your neck and seeing if you're using any of your anterior neck muscles to aid in raising your chest wall, which would be a sign of accessory muscle use. And since I don't see any immediate signs of distress right now, I know I can triage this visit and proceed with a usual physical exam as opposed to seeing you in any level of distress where I might need to take immediate actions. I'm noticing that your effort in breathing is relaxed. The depth in which you're breathing also doesn't appear to be that you're straining and trying to take deep breaths or breathing too shallow. And your rate of breathing appears normal and regular. I'm going to just take your respiratory rate here, so just continue to breathe normally. Great, so I got a value of 12. And again, I noticed that your rate rhythm was appropriate and what I would expect. So furthering my observation, I'm just going to look at your chest wall here, and I'm going to notice if you have any increase in the anterior posterior diameter of your chest, and looking for any chest wall deformities that would be obvious to me given that you're wearing a gown. And I'll inspect the skin and the structure of your chest a little bit later when I look at the back and the front. But while you're here, I'm now just going to take a look at your hands. Feel the temperature of your hands, look at your capillary refill, looking at making sure you have good vascular flow to your hands. If I notice any clubbing in your fingers or decreased capillary return in your fingers, temperature changes, color changes, those would be indicative that you may be not getting enough oxygen. While I'm here, I'm also just taking note if I hear any sounds of breathing, noticing if from here, even without using my stethoscope, if I notice that you're having any wheezing or any noises with your respiration. So now that I feel like I've done a pretty good overall screen to see, check for any respiratory distress and get a general idea of your respiratory health, I feel like I'm going to have you now turn and face that wall for me. Okay. Do you mind if I undo your Johnny back here?
That's fine.
Okay. So I'm going to try to keep you covered here, but I'm going to try to look at the skin of your back. If you're coming in with a respiratory complaint or any kind of chest complaint, I want to make sure there's no skin lesions or any big deformities that I notice of your chest wall. But your chest wall looks symmetric. Okay. I'm going to palpate here. Okay. So just let me know if anything is tender. And I'm also noting any asymmetries from side to side and tissue texture changes. Okay. So I'm going to feel levator scapula and trapezius, all muscles that attach to the chest wall, rhomboids, latissimus dorsi, okay, and feeling along your paraspinal musculature of your thorax, just trying to get an overview to see if I see any gross abnormalities there as well, okay. So now I'm going to just palpate behind your, in front of your trapezius here, and have you take a deep breath in and out. Great. So I'm feeling nice symmetric rise and fall of your first rib here. So now I'm going to just get a general feel of your upper ribs here. Go ahead and breathe again. Excellent. So I'm getting good symmetrical rise of your chest wall. Just going to put my hands here along your lower chest. Go ahead and do that again. Okay. And I notice that my thumbs are coming away from midline and returning back to midline at the same exact spot and at the same timing. So I'm not concerned about any large asymmetries in the chest wall. I'm going to evaluate the rib function a little bit in a little bit more detail when we evaluate the anterior chest. Okay. Something that I forgot to mention that I'm also doing when I'm palpating down is looking for any prominence of the ribs. Okay. So I want to see if there's any posterior subluxations or anterior subluxations of the ribs. On these rib angles, I will also identify any tender points that would be associated with those ribs as well. And then once the last thing I would want to evaluate is for any thoracic dysfunction that may be associated with that. So I can do a general screen looking for any asymmetries there. Okay. Now that I've done a palpation and observation exam of the back, I'm going to start my oscillatory exam. So to do that, I'm going to use my stethoscope. And what I would expect to hear here would be vesicular or bronchovesicular sounds. And typically once you're further away from the respiratory tree, they tend to be vesicular, which are finer sounds, and bronchovesiculars are a bit more coarse. But that's what I'd be expecting to find. And so I'm going to listen to 7 spots on each side of the back here. Okay? And I'm going to do this in a ladder formation. So I'm going to start up here. Every time you feel my stethoscope press against your back, I want you to take a deep breath through an open mouth. Okay? And if at any point you're feeling lightheaded or like you can't continue to do that, just take a break and just let me know. Okay? So go ahead and start. Excellent. So I heard good air entry bilaterally. I noticed you were able to move air symmetrically throughout your lungs. Other things that I would be looking for when I'm doing that would be for any wheezes, rales, rhonchi, or any friction rubs that may exist between the 2 layers of the pleura. So now that I've done that, I'm going to go through and do the percussion part of the exam. So I'm going to percuss over those same areas, and what I expect to hear is a resonant sound. And so I'm going to apply 1 finger here. You just relax, you don't have to do anything, okay? Great. So it was resonant to percussion bilaterally. Okay. So next I'm going to go into some special tests here that you can also do in the lung exam should you find any pathology. So the first thing I'm going to do is something called whisper pectoriloquy. So what I'm going to have you do is whisper the word 99, and what I'm going to be listening for is increased transmission of that sound. Typically I should hear a muffled sound, and if I hear increased transmission of that sound that you're making when it's whispered, that could be an indication of some sort of pathology that's increasing the transmission. So again, every time you feel my stethoscope, go ahead and say, whisper 99.
99. 99.
Great. So the last thing I can do, why don't you take a break for a second? The last thing that I can do is something that's called egophony. So what I'm going to do is have you say a word with the letter E in it. So for this case, I'm going to have you say key. And what I'm looking for is a change in that sound. And if it comes out sounding more like the letter A, then that could also be a sign of some sort of change in the transmission of sound from the lung into the chest wall. Okay? So every time you feel my stethoscope, go ahead and say the word key. Okay?
Key. 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 Key.
Great. Next, I'm going to perform tactile vocal fremitus. And so I'm going to put the hypothenar aspect of my hand and my pisiform bone up against the posterior chest wall. And I'm going to be checking for the transmission of your sound through to the chest wall. Okay? So I'm going to put my hands on both sides, and I'm going to be comparing bilaterally. Okay? So just say the word baseball.
Baseball. Baseball. Baseball. Baseball.
Okay. So I felt that vibration come in symmetrically to both of my hands, and so I would say that that is an appropriate response to tactile vocal fremitus. So the last thing that I want to do here is check your diaphragmatic excursion. So what I'm going to do is I'm going to make sure that we're getting a symmetrical fall from your diaphragm with deep inhalation, okay? So the way that I'm going to do that is I'm going to start up high and percuss down to where it changes from resonant to dull, okay? And then I'm going to have you take a deep breath in and hold it. And I'm going to percuss down to where I hear dullness again, okay? So that is about probably about 4 to 5 centimeters, and that is what I would expect for a diaphragmatic excursion. So when you breathe in and hold it, that diaphragm is going to drop, and it appeared to drop the appropriate amount, okay? So I'm going to do the same thing on the other side. Just relax for a second until I find the area that is dull, okay? And I'm noticing it's dull at the same spot on both sides. Now let's have you take a deep breath in again and hold it. Excellent. So again, about 5 centimeters on both sides, so they're bilaterally symmetric, and I am seeing the appropriate drop in the diaphragm as what I would expect. Okay. So now let's transition into an examination of the front. So I'm going to have you lay down on your back. So now that I have you supine, I'm going to do essentially the same exam I did in the back on the front. So the first thing I'm going to do is inspect the skin here. So I'm just going to lower down your Johnny a little bit here. Okay. And I'm going to sort of break up this exam into 2 parts, do the upper part, and then look at the lower part. Okay. So I'm looking at the skin, looking for any lesions, deformities that I notice, checking out the clavicles, they look symmetric, looking at the sternum, looking for any sternal abnormalities, you know, pectus excavatum or carinatum. I'm looking at the size and symmetry of your pectoralis muscles, and everything looks symmetric here, and I don't notice any skin lesions that I'm concerned about. So I notice that there are no chest wall deformities here, and your chest is rising symmetrically with respiration. So I'm just going to palpate first. So I'm going to palpate your sternoclavicular joint and your clavicle, feeling the pectoralis muscles. Okay. Any tenderness?
On the left.
On the left, yeah, and I'm noticing some tissue texture changes here. So that may be relating to the chest wall, so I'm going to just take note of that. I'm also going to feel your motion of your upper ribs. So I'm going to start with the first rib. Can you take a deep breath in and out? Great. So I'm noticing symmetrical motion there. And I'm going to place my hands over your pump handle ribs here. Go ahead and breathe in and out. Excellent. I'm feeling symmetrical rise and fall of your chest wall there. Okay. So now that I've inspected and palpated and I have felt your rib motion, what I'm going to do now is I'm going to auscultate. So I'm going to start with the apices of the lungs, which are right up here above your clavicles, okay? So just like before, what I'm going to have you do is take deep breaths through an open mouth so I can get the best appreciation of your lung sounds. So let's have you face towards that way, okay? And go ahead and take a deep breath in and out. Excellent. Again. Okay. I'm going to find your second intercostal space here. Go ahead and breathe in and out. Excellent. I'm going to move down to your fourth intercostal space here. Go ahead and breathe again. Excellent. So I'm going to go ahead and do tactile vocal fremitus over those areas. So go ahead and say 99.
99.
Again.
99.
Great. And I'll do the lower ones afterwards. So the next thing I'm going to do is percuss. Okay. Okay. So your lungs were cleared auscultation in the upper fields. I noticed that tactile vocal fremitus was present and symmetric bilaterally, and to percussion, it appeared that there was resonance. Okay. And I didn't on the auscultatory exam hear any wheezes, rails, or rhonchi, which would be what I was looking for, and even I heard even air entry. Okay. So now for a couple of tests, I'm going to do the whispered pectoriloquy again. Okay, so go ahead and whisper 99 for me again.
99. 99. 99. 99. 99. 99.
Great. So I didn't notice any increased transmission of that sound. Okay, and now let's do egophony again. So say key.
Key. Key. Key. Key. Key. Key.
Okay, great. So it sounded like key. I didn't hear any conversion of that key to K, which would be indicative of a change in the transmission of sound there. Okay, so now that I've observed the skin, palpated the ribs, palpated the musculature up here, auscultated, percussed, tactile vocal fremitus, and my other two special tests, I'm going to move to the lower chest. So I'm going to cover you up here, and I'm going to do the same thing I just did, but I'm going to lift this up. Okay, keep you covered there. And now I can observe the skin of the lower chest wall, looking for any lesions or abnormalities there. Okay, I'm going to go ahead and palpate if that's all right with you, and I'm going to palpate along serratus anterior. Okay, any pain?
No.
Okay. I'm also noting if there are any subluxations anterior posteriorly with the ribs. I did do that up above, but I didn't comment on that, but I'd like to comment on that now. I'm also going to feel for the respiratory motion, so go ahead and take a deep breath in and out. Great. The other thing I'm going to note here is your subcostal angulation. Okay, I notice it's about 90 degrees along your costal margin to your xiphoid, which is what I would expect. If I notice an obtuse angle, that may indicate some flattening of the diaphragm. Okay, so you don't have any sublux ribs. You have good respiratory motion. You have an acute subcostal angle. You didn't have any tenderness to palpation that I noted. So I'm going to actually evaluate your axillary lymph nodes now. Okay, so I'm going to palpate into your axilla, and I'm looking for any enlarged lymph nodes. Okay, I'm going to do the same on this side. Okay, great. So I didn't feel any enlarged lymph nodes there or any masses that I was concerned about. Okay, so I'm going to proceed. I've already evaluated the apices and the two superior lobes here, so I'm now going to evaluate the middle lobe and the lower lobes down there. Okay, so I'm going to auscultate again. Okay. So I'm auscultating over the lingula here. So go ahead and breathe through an open mouth as deeply as you can, okay? Great. Great. So now I'm going to perform the rest of the percussion exam. So I already evaluated the apex, the second, the fourth intercostal space. So I'm going to get the fifth intercostal space here, and then bring it out laterally to get the fifth and sixth. Okay. Okay. And all of those were resonant to percussion, so nothing concerning there. The next thing I'm going to do is finish the tactile vocal fremitus. So I haven't gotten this lower region here. Go ahead and say 99 again.
99.
Okay. So I felt the resonance there, and it was full and symmetric. It wasn't diminished or increased on one side compared to the other. Okay. So now I'm going to do the couple special tests. Okay. We're going to finish doing whispered pectoriloquy and egophony. Okay. So let's have you whisper 99.
99. 99. 99. 99. 99. 99.
Great. And then go ahead and say key again.
Key. 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 Key.
Okay, great. So it was the appropriate transmission through the chest wall as I would expect for both those tests. So I auscultated, percussed, tactile vocal fremitus, egophony, whispered pectoriloquy, and now what I'm going to do is percuss over the interface here between the right lung and the right side of the diaphragm here, okay? And so I'm going to start up here, percuss down till I hit the dullness of where the diaphragm, the lung meets the diaphragm and the liver. Okay, so that's dull there. Now I'm going to have you take a deep breath and hold it. So that's resonant again. Great. So that's about 3 centimeters. So that's exactly what I would expect. So that would help us determine if anything in this, this right middle lobe sitting over the liver, if there was any issues with filling or that part of the lung, or aerating that part of the lung. So it was resonant throughout and it moved the appropriate amount, so I'm not concerned about the movement of the diaphragm there. So I believe that would conclude our osteopathic exam of the lungs.